So, good evening and thanks to everyone for joining us today. We welcome you to the webinar organized by Haryana Chapter ISAR, and technical partner for this webinar series is Jacksonpal Pharma, makers of Endorec, Divatron and Injection Maintain. So, we present to you Endorec micronized Dynogest 2 mg in endometriosis associated pelvic pain. We have Devatron 10 mg micronized tablets of dydrogestrone to improve compliance. And we have injection maintain 250 and 500 mg of 17 alpha hydroxyprogesterone caproate to maintain positive pregnancy. So, warm and hearty welcome to all the esteemed faculties and attendees. Please note this webinar is streaming live on Facebook and the link has been shared in the chat box. So to refer to this webinar in future, please visit our YouTube channel, Jacksonpal Pharma Medical Insights. Now, we invite Dr. Jyoti Malik, Chairperson Haryana ISAR and Director Roots IVF at JJ Institute of Medical Services, Bahadurgarh, to kindly initiate the program. Over to you, ma'am.
Yeah, thank you so much. Thank you, Nimisha. Thank you, Jacksonpal, for the platform. And it gives me great pleasure to invite you all for this Inspire Ignite Series 19 that we constantly hold every month religiously. And this is the 19th episode under ISAR Haryana banner with the motto that we have of Prayas Evam Vistar. So constantly working to expand both for ourselves and for the patients. So with this motive, we bring you this webinar today, which is for which we have two great speakers. And before that, I would like to take blessings from our National President, ISAR. Can we have his CV? Nimisha, yeah, Dr. Ameet Patki, sir, and the Medical Director, Fertility Associates, Mumbai. Dr. Ameet, sir, is our President, National ISAR, with a lot of publications, book chapters, and so many patents, international patents in infertility and stem cells with research and TEDx speaker, and is a wonderful, wonderful leader. And also our Secretary General, Dr. Asha Baxi, ma'am. So Dr. Asha Baxi, ma'am, another very personality which always brings a lot of positivity to any particular meeting or conference. And she is a lead consultant at Dr. Asha Baxi Fertility Indore. So we take blessings from both of them because every time they are there to backen us up, to support us, and to give us the momentum to do things. So today we have our chairpersons. We have Dr. Maninder Ahuja, who is the past president of ISAR Haryana, a very senior and learned lady, and a very enthusiastic person, young at heart. Then we have Dr. Meenu Bhakar and Dr. Anjali Bansal. Dr. Anjali is from Sonipat and Dr. Chavi from Bhiwani. So these are our chairpersons. And can I request Dr. Chavi, if you are there, to please introduce our speaker. So we have a wonderful speaker, and thank you, Dr. Jatin sir, for accepting our invite, because I know you are a person who is too busy, but I think you are as humble as you are the person with you have the experience that you have and the hold on the subject that you have. But I think just one phone call and you accepted our invitation. So Chavi, can you please introduce Dr. Jatin sir? Nimisha, please display sir CV. We didn't formally did not take a CV, but I think maybe from the Facebook we could get something.
Good evening.
Yeah.
Good evening, everyone. This is my pleasure to introduce sir. Ideally, he needs no introduction. He is MD and DGO. He is IVF consultant at Mumbai Fertility Clinic, and he has successfully established pregnancies in more than 17,000 infertile couples since 1994. In 1995, won first prize in the best paper presentation for the topic of IVF and tubal factors fertility. In 2003, he was awarded as Young Personality of the Year by the governor among 10 outstanding young Indians. He has been associated as a guest speaker, faculty, panelist, and guest orator in more than 300 national and international conferences. Founder member of Aspire, having numerous presentations and publications, national and international, and he is extremely well versed with IVF, ICSI, IUI, oocyte donation, sperm donation, embryo donation, and gestational surrogacy. And currently, he has performed close to 2,000 cycles of IVF and ICSI per year, with an average of 80 to 100 IVF pregnancies every month. It's an honor, sir, to have you here. So, ma'am, can we start our talk?
Yeah. Over to Dr. Jatin, sir.
Yeah, thank you so much, dearest Jyoti. Thank you, Dr. Chavi, all the chairpersons. It's a pleasure to be here today, of course, and on a very important topic. I'm also looking forward to hearing Dr. Surveen's talk, a very different topic, and it seems to be very exciting. So I'll just share my screen. Yeah, that's it. So today, of course, we have to talk about a very important topic. Basically, it's the most important step in your entire IVF cycle, and that is how to go about ovarian stimulation in a very individualized manner. And what are the recent advances, some of the very exciting advances that we have for our difficult category of patients, especially the Poseidon's 3, the young patients who come to us with very low AMH levels, and also some of our PCOS where we still struggle with miscarriages. So to begin then, of course, we have to remember that we are all here thanks to the trio of Sir Robert Edwards, Dr. Patrick Steptoe, and Jean Purdy, who gave us at the stroke of midnight, 25th July 1978, Louis Brown. And I'm sure all of you must have watched the movie Joy. But the reason I put this slide is that when I began practice 35 years ago, we had just 3 hormones available to us. One was buserlin acetate from the grey market. We had metrodin, which was simple urinary FSH in ampules of 75 IU. And we had pergonal, which was simple urinary HMG in ampules of 75 IU. And we had just 2 standard protocols. If we felt that she's going to be a normal responder, it would be a down regulation with M2P1, that means 2 metrodins, 1 pergonal, which meant that we gave a 225 to 75 ratio of FSH to LH, that is 3:1. And if we felt she's going to be a poor responder or she's a woman of advanced age, we would use M3P2, which meant 375 of FSH and 150 of LH. And then came the big pharma wars, and we went on from urinary to purified urinary to highly purified urinary to recombinant to filled by mass. And now again, we are being told that the best ratio is to give a 3:1 or 2:1 ratio of FSH and LH. And we now have ready-made pen devices available with these ratios. So basically, the end point here is that we've turned a full circle of life or circle of gonadotropins to come back where I started exactly 35 years ago. But of course, it's not as simple as that anymore. And we know that today we are in the times of individualization. So you cannot have one standard protocol for every patient who walks in, especially clinics like ours, where almost 70 to 80% of patients are those who have failed IVF somewhere in the world in the past. We have to give a lot of attention to detail and protocol. And to help us individualize our treatment, we always take into consideration, as all of you would too, age, BMI, AMH, AFC, how she responded in previous cycles, does she have associated PCO or endometriosis? But the most important factor, especially if a patient has done an IVF cycle in the past, the most valid point for you to select a particular protocol or a particular dose of FSH and LH besides AFC and AMH is what was her response in the previous cycle. So you need a detailed analysis of what was the protocol used, what was the analog used, which FSH was used, was it a recombinant, was it a urinary, was it HMG, what was the ratio of FSH and LH, what was the day of the trigger, did she have follicular asynchrony, did one follicle race ahead on day 7 and the others were lagging behind, did she have a lower output of metaphase 2 oocytes as compared to the number of follicles that you had and that you expected? Was a fresh transfer done? Was a frozen transfer done? Was a day 3 transfer done? Day 5 transfer done? And what was the luteal phase support? And only if you go into all these details, you might be able to find some ray of light that what good changes could you make to then give her successful IVF live birth. But despite all our best efforts with individualization, we are still faced with the problems of the poor responder. And I'm sure all of you would agree that almost 60 to 70% of our patients today, at least in the big urban centers, are one of these four categories. So simply put, we all follow the Poseidon groups, and we know that Poseidon 1 and 2 are young and old patients. They come to you with a normal ovarian reserve, but somehow, despite your best efforts, they don't give you a good crop of oocytes. You either end up as a group 1A or 2A with less than 4 oocytes, or group 1B or 2B with 4 to 9 oocytes, where you actually expected 15 to 20 good quality oocytes. And then you have your Poseidon 3 and 4, which are young and old patients who come to you with a reduced ovarian reserve. You are well prepared that she is not going to respond well, and therefore you have enough time for pre-treatment and for selecting an appropriate protocol for these patients. What about success rates? And this is where there is a bit of heartening news and good news, that just because she has a low AMH, but if she's 30 or 32 years old, so I'm talking about Poseidon 3, which is our commonest subgroup of patients, the success rates are still pretty much very good. So you can see here clinical pregnancy rates 47.9 versus 53.6 in a normal responder group. So there is not too much of difference. So this is a very important point when counseling patients, that just because you have a low AMH doesn't mean you are going to have higher risk of miscarriages or going to have lower clinical pregnancy or live birth rates. But yes, we have to pay a lot of attention to the protocol to make sure that if you are getting even 4 oocytes, you need to get at least 4 or at least 3 metaphase 2s to give her that 1 or 2 top quality embryos, which could result in a live birth for that patient. So let's begin with what's new. Is the Poseidon classification enough? Is it enough to categorize patients on just the basis of age and number of eggs and the AMH and AFC levels? And which is why there is a lot of research going on the various mechanisms which explain a poor ovarian reserve. So more and more attention is being paid not just to genetic competency and PGT programs, but mitochondrial and metabolic dysfunction, which we know can result in follicular growth defects, especially in the Poseidon 4. Genetic or DNA repair defects, which could cause accelerated follicular attrition, epigenetic dysregulation resulting in poor oocyte quality, polymorphisms and SNPs, which again would give you an unexpected poor response despite a normal AMH level, altered mitochondrial RNAs, developmental or environmental exposures, and so on. So these are the various areas which we need to pay attention to in order to do better and better for the poor ovarian responder group. But for a deeper understanding, there is a new classification telling us the 4 stages of a diminished ovarian reserve. So the first is, of course, a well-compensated stage. She comes to you with a low AMH, high FSH on day 2, normal E2 on day 2. She will develop a follicle which will grow beyond 18 millimeters in size, and she will have a normal cycle length. So this is the group you don't really need to worry about. Your protocol and your good dosing of FSH would generally result in a good outcome. The stage of desynchronized cycles is the one you really need to be wary of. And this is the stage of patients, group of patients, where follicular asynchrony is very common. And the clue to diagnose this is that she will have a low AMH, she will have a normal FSH on day 2, but she will have a high E2 on day 2. And what is the source of this high E2 on day 2? It means that the follicular selection has already happened in the late luteal phase of the previous month. She will go on to develop a mature follicle beyond 18 millimeters. But because she's completed 2 to 4 days of the follicular phase in the late luteal phase, she will tell you that she has a short cycle length. Now here, if you begin stimulation on day 2 with your routine antagonist protocol, you will definitely end up with asynchrony, because the follicle which has already been recruited will be 15 or 16 on day 7, and the newly recruited follicles with your exogenous FSH would probably be lagging behind at 10 to 12 and which is why you don't get a good cohort of metaphase 2 oocytes. Many a times I get a call from some IVF clinic somewhere in India that, oh, yesterday the follicles were 15 to 16 I gave her antagonist. I called her back today thinking I will trigger today or tomorrow, but she came today with follicular rupture. Or many a times when you take the patient up for an egg retrieval, you find that the eggs have already ruptured, the follicles have ruptured. So these are the patients who have pathological premature LH rises, aberrant premature LH rises. Even if you have started the antagonist at the right time, these surges have started either before or after initiation of the first dose of the antagonist. So again, you have a low AMH, you have a high FSH, you have a normal E2, you have a tendency to a pathologic premature LH rise, and you will have short cycles because of premature rupture of follicles before they reach 18 millimeters or so. And finally, of course, you have the very, very severe cases of diminished ovarian reserve, very low AMH, 0.1, 0.2, very high FSH, 20 or 30, very low E2 levels, totally suppressed follicle growth. Hardly you see any antral follicles in the ovaries. They have long and irregular cycles, probably premenstrual, and usually nothing works for them except resorting for oocyte donation. So once you understand the pathophysiology, you will then realize why protocol selection is so important. So when we look at Poseidon 1 and 2, to understand management, as I told you earlier, you have to understand the importance of getting a total 90 to 100% percentage of M2s from whatever few oocytes you are going to get from these patients. And that it is so important because we know that to get one top quality embryo, on an average, you need 3 mature metaphase 2 oocytes. And does every extra oocyte really count? Yes, it does. As Bosdijk showed in 2017, if the expected live birth rate with one oocyte is about 4%, the expected live birth rate with 4 oocytes is almost 16%. So this shows you the importance that if you have 5 follicles, why you should be aiming at 4 or 5 metaphase 2s. And the only way you will achieve this is if you trigger at the right time and if you have a perfectly synchronous cohort. And even Sankara's study here, where we kept focusing on the fact that beyond 15 oocytes, fresh embryo transfer pregnancy rates are low because of supraphysiologic estradiol progesterone levels. But if you again closely look at this graph at the beginning, from one oocyte, we can see how the graph steeply rises with every additional oocyte that you get up to 5. And this is the group that we are going to focus on today, the one which gives you less than 7 or 8 or 9 oocytes in your program. The second most important thing is oocyte competence. So it's not only enough to get good numbers, but you also need to get oocytes which are genetically and mitochondrially competent. And this is because we know, as Benedict showed us, that if you consider a pregnancy as 100%, the contribution of the sperm and the uterus is probably 10% each, but the egg is responsible for 80% of a successful IVF outcome. And this is important because we keep paying too much attention to genetic competency and keep on insisting that PGT is the answer to all our woes. But please remember that we have more and more research and inputs now that the mitochondrial genome is more important or equally important as the genetic imprint of the oocyte. So looking at the possible causes of getting Poseidon 1 or 2, maybe your gonadotropin dose was lower than what it should have been. The second, maybe she's a carrier of a polymorphism, which makes her ovaries insensitive to exogenous gonadotropins. Maybe your trigger was not right or was inadequate or was a day early or a day or two too late. But the most important and the commonest cause of getting or producing an iatrogenic Poseidon 1 or 2 is almost always asynchronous follicular development. And asynchrony, just to divert a little, not only applies to these poor responders with the antagonist protocol, but is also seen in some PCO patients where you begin with very high dose of FSH, say 300, and you will see again 2 or 3 follicles racing ahead and the others lagging behind, finally not giving you a very good output of top quality embryos. So let's look at the Indian studies for Indian women, and you will clearly see here, as Fadi and Padmarekha showed, that for predicted normal responders, minimum dose, starting dose for an Indian woman should be 225 or 300 and not less than that. And the problem is that when we pick up a fertility sterility and we read materials and methods, or even European studies for that matter, we often see that they just give doses of 150 rec FSH and still get 9 to 10 or 20 oocytes. So please remember that there is a difference in the sensitivity of the ovaries. There are racial and genetic differences, and it is high time that we have Indian studies on the way our women respond so that we don't go wrong with the stimulation and produce more and more Poseidon 1s and 2s. The second most important thing, polymorphisms. Wonderful study here from 2023 showing the various high-risk genotypes which are associated with a poor or a hypo response to COS in Indian women. And we must be aware of these so that we can start with higher doses of FSH or give them a good amount of LH right from the beginning of stimulation. So remember, for polymorphisms, patients who are homozygous for serine require more gonadotropins. They often have these very long follicular phases of 10, 15, 20 days, higher basal FSH and lower E2 levels compared with the normal aspergine counterparts. And even patients with a variant of the beta subunit of the LH gene may also need not only a higher dose of FSH, maybe 75 or 150 IU more, but they need 150 and not just 75 of LH right from the beginning of stimulation to prevent those stagnant follicles and ensure a fast growth of the follicles at a normal pace. But coming to asynchrony, the most important factor in your antagonist cycle is to ensure that you do not produce follicular asynchrony. And it would be very unwise to begin stimulation when a patient has walked in late on day 2 or early on day 3 with a low MH level, and you just begin stimulation and then you end up in a mess with asynchrony. So it's very important to do some form of pre-treatment, and the commonest methods used, the first being luteal estradiol valerate, very popular, very easy to use, 4 milligrams a day from day 25. The beauty of the 4 milligram dose is that it does not suppress menstruation. So she will menstruate at the given time, at her regular time. You just continue the estradiol valerate. Suppose she walks in on a Monday with day 2. You don't want to start stimulation because you don't want an egg retrieval on a weekend. You continue the estradiol valerate until Thursday, begin stimulation from Friday, and then go ahead with your addition of the antagonist. Now here you will not, the menstruation will stop because of the estrogen. You will have a triple line on Friday. You don't have to worry, but you will not see any dominant follicle because of the negative feedback of estradiol. So when you then begin FSH, you will generally get a uniform and synchronous cohort of follicles. Second common method used is just norethisterone BID from the mid-luteal phase. Try to stop on a Sunday and begin stimulation on a Friday. The third, not too popular, oral contraceptive pills from day 2. Try not to give more than 10 to 12 days. Again, follow the same rule of stopping on a Sunday, starting stimulation on a Friday, and give the mandatory 5 to 7 day washout period to avoid a low response to stimulation. And very important, and something which really works well to ensure synchrony, is the use of the antagonist, and that is what we call stop-start antagonist. So you give antagonist on days 2, 3, and 4. You then begin stimulation from day 5, which would then be designated as the new day 2. And you then add your antagonist at 14 millimeters or as a fixed 5th or 6th day of gonadotropin start, whatever your general policy is. So this has the advantage of suppressing any dominant follicle which might have been selected and ensuring a perfect synchrony in the subsequent response to stimulation. Now, a lot of you would argue about the birth control pill that if you pick up a fertility sterility, almost every clinic in the US uses birth control pills. How come they don't have a problem with subsequent response and recovery of good mature oocytes? But if you go on and read the material and methods in more details, you will also notice that all US clinics always begin stimulation with a combination of FSH and HP-HMG. So if you have given a birth control pill for scheduling, for avoiding weekend work, for compiling your batch together, and you are stopping all of them on a Sunday, please remember that you have to add LH right from the beginning to counteract the adverse effects of the prolonged OC pill administration that you have done for scheduling the particular patients on a particular day. So 5 day to 7 day washout period and beginning with FSH and LH will permit you to use the oral contraceptive pill for more than 10-12 days. But otherwise, if just stick to 10 days if you plan to begin stimulation only with REC FSH. But finally, which is the best method to really take care of the stage of desynchronized cycles, to take care of pathologic premature LH surges, and to really do justice to follicular synchrony? And that is where you have this ongoing debate between the antagonist and the long agonist protocol. Now, which of these two will give you a perfect synchrony? Which of these two will ensure that there is no selection of the dominant follicle in the luteal phase, no premature LH surge, more oocytes with better cytoplasm, more zygotes with a normal 2PN morphology, total synchronization, higher number of oocytes and embryos, and most importantly, today we are in times where we do not want to follow freeze all for all anymore. because of the concerns of PIH and macrosomia. So if you want to do more and more fresh transfers, does the agonist or the antagonist give you a better endometrium? And hands down, it is the agonist which scores on each and every one of these points. So the agonist long luteal protocol is the only one which can take care of all the issues with poor responders and make sure that you get a good outcome. And some recent studies here which clearly show rejuvenation of the agonist protocol. And this was a large study in 2024 where they compared the agonist versus the antagonist in the first IVF cycle of a patient and clearly showed higher number of oocytes and a 7% higher ongoing pregnancy and live birth rate in the agonist versus the antagonist group. Of course, we had Huang study in 2018, again showing that in your large group of Poseidon 3 young patients with low AMH levels, agonist likely to give you a live birth rate of 31% versus 16.7% in the antagonist group. There are also studies that show that even in Poseidon 4, you can see here a study from 2020, patients with the AMH between 0.7 and 2, again, the agonist protocol achieved significantly higher cumulative live birth rates than the use of the antagonist. And why are the pregnancy rates lower with the antagonist? So we already spoke of the tendency to premature LH surges, which can occur in 8% of fixed start antagonist cycles. 80% of these surges occur before day 6, that is before you start your first antagonist. And to repeat again, asynchronous follicles and large forerunner follicles, which you often see in the short antagonist protocol. But most importantly, from the point of view of fresh embryo transfers, with the antagonist, you have significantly lower hoxaten expression in the endometrial stromal cells, which is responsible for lower pregnancy rates when you are planning a fresh embryo transfer for a particular patient. So to end on the agonist part, clinical take-home points for all of you for the agonist. Agonist protocol should be your first choice when maximal synchronization and oocyte yield is critical, so all your poor responders. Antagonist protocols, of course, for the high responders, there is no question of using the agonist because we don't want ovarian hyperstimulation. And if her previous IVF cycle has shown clear asynchrony as one of the main reasons for failure, you must switch to the agonist protocol to get a much, much better outcome for her. And the last point, of course, is the use of the trigger. Many a times we find that you had 10 follicles, but you got only 4 oocytes, or you had 8 oocytes and only 3 were M2s, and so on. And most often it is because of trigger issues. And this is where the agonist trigger plays such an important role, and more importantly, the dual trigger. Now, if you just look at the normal menstrual cycle here, you will clearly see that at the mid-cycle, you don't have only a LH surge, but you also have a small rise in FSH. So it is both FSH and LH surging at that ovulation time that are responsible for the final meiotic maturation and final conversion to a metaphase to oocytes. So when you give an HCG trigger, you are only simulating the LH peak and you are not giving her any FSH activity. So the agonist trigger is more physiological, induces both FSH and LH surges, but the problem is that the agonist trigger alone has a very short half-life. There is abrupt luteolysis, so you cannot plan a fresh embryo transfer if you use the agonist trigger alone. And therefore, it is proposed that for poor responders, you must give a dual trigger. You give her HCG 6500 rec HCG with 0.2 milligrams of triptorelin to ensure that you have a very huge increase in the live birth rate from 14.5 to almost 27%, as this study in 2019 showed. If it is a freeze-all cycle or a PGT cycle, is the agonist trigger alone, in fact, better than HCG? And yes, that's true. You can see here the cumulative live birth rate from embryos generated using an agonist trigger is the blue line, much higher than the cumulative live birth rate that you get from embryos generated from an HCG triggered cycle. So given a choice, if it's a freeze-all cycle, your first choice, even for all oocyte donors, should be just the agonist trigger, and there is no use or no need to give these patients an HCG trigger. One of the commonest inquiries that I always get is, oh, I got empty follicles, what do I do? Please remember that whenever you are using an agonist trigger, empty follicle syndrome is likely or definitely going to happen in hypogonadotropic hypogonadism, because the agonist works on the principle that there is an endogenous stock in the pituitary of FSH and LH which will be released with the agonist. In hypo patients, there is no endogenous stock, which is obvious. So you have to use an HCG trigger even if she has 20 or 30 follicles. Prolonged follicular phases, sometimes the agonist trigger results in empty follicle syndromes. Excessive gonadotropin use, especially if more than 3,800 total gonadotropin has been given during the cycle. Some of your poor responders, again to reiterate, OC pill use, because extended OC pill use will result in very low or suboptimal LH levels at the beginning of stimulation. And because of the very low endogenous LH, you will not get a good surge of LH when you give the agonist. Very low estradiol or LH levels on day 2. All these could contribute to empty follicle syndrome. And this is, of course, the false empty follicle syndrome, which is the commonest variety where the patient is not having any genetic issues on her mutation analysis, and it is purely because of something having gone wrong with the timing or the nature of the trigger. Interesting study here that how does the trigger timing, the timing between the giving the trigger and the egg retrieval vary between the agonist trigger and the HCG trigger. And a very recent article, 2025, intervals of more than 36.5 hours are better when you use an agonist trigger alone, and intervals of less than 36 hours are better when you are using an HCG trigger. And this benefit is especially seen among older age groups, where, instead of your routine 36, if you pick up oocytes at 37 or 37.5 hours with the agonist trigger, you are likely to get a better outcome and more metaphase 2 oocytes. We then move on to Poseidon 3 and 4, that is your young and old patients who come to you with a reduced ovarian reserve. And here, of course, you have time for your 2 months of pre-treatment. The only evidence-based supplements that really work are DHEA or testosterone, coenzyme Q10, and growth hormone. So these three are the only ones which have the most evidence and the most papers published that they actually work. And we know that synergistic combinations of ubiquinol and resveratrol are also very popular. And we also have L-leucine, glutathione, our own shatavari and ashwagandha, which also are useful antioxidants for helping in improving oocyte quality in patients of Poseidon 3 and 4. But coming to more important androgen supplementation, we had this paper in 2022 that testosterone pretreatment yields a higher number of oocytes and better live birth rates. And generally what I do in practice is 21 days of the gel. So we call her in day 6 of the cycle before the stimulation cycle. She uses the testosterone gel for about 20 days. And then when she comes in on day 2 to begin the antagonist cycle, she would have completed her 20 days of testosterone. How high should you go in Poseidon 3 and 4? Now remember, these patients don't have follicles. So going beyond a certain dose is not going to give you more follicles. And in fact, very high FSH doses are detrimental to final oocyte quality. Many a times you find the embryologist telling you that the zona was fragile and the oocytes were bursting when the sperm was being injected. This is usually because of very high FSH dosing in predicted poor responders. So please don't go beyond 300, maximum 450 if she's say 40 or 42-year-old. Beyond that doesn't really help. Pay more attention to LH supplementation. So it's very well established now that LH supplementation is important for all women above the age of 35. For all hypo responders who are stagnant with their follicles for 4 or 5 days, they just remain at 12 mm, 13 mm. These are the patients who need LH right from the beginning of stimulation because they are the likely carriers of polymorphisms. All patients with hypogonadotropic hypogonadism, the correct starting dose of stimulation for these patients is 300 IU of FSH and LH right from the beginning to give you a good ovarian response. All Poseidon groups, of course. And now there are recent studies showing that even in PCO patients, you might need to give LH for some subgroups who are more prone to early pregnancy losses. So recent evidence, again here, a study comparing REC-FSH alone versus a combination of REC-FSH and HP-HMG, and clearly higher estradiol levels, better fertilization rates, and higher blastulation rates and more blastocysts available for transfer in the combination group as compared to REC-FSH alone. Commonly in India, we have a tendency to switch to HMG on day 7, and we use recombinant FSH alone from day 2. This study is very important from 2021 that early follicular HMG is more important. You can see here if you begin HMG right or add LH from day 2, your live birth rates would be around 22%, as against switching on day 7, where you don't have a really high live birth rate and just struggling at about 12%. So there is a very strong association between the commencement time of LH and the live birth rate for Poseidon's 3 and 4. What about embryology add-ons? And it's become fashionable now that, oh, you are a poor responder, so you should do PGT. You are a poor responder, so you should do ICSI. What is the truth? And if you look at it, there is absolutely no evidence that ICSI is of any benefit in poor responders. Just because she has 3 oocytes does not mean that ICSI will give you a better outcome. Just because she is 38-year-old doesn't mean that ICSI is to be preferred over IVF. And we have paper after paper proving the same. In fact, I have a whole lecture on IVF versus ICSI, and most clinics have just abandoned conventional IVF, which is not the right way to go, especially in the light of this study from June 2023, where they followed up 2 lakh infants at Johns Hopkins, and they found that when ICSI is done in the absence of a male factor, you are increasing the risk of birth defects by 30%. So please be wary of this. And IVF is not any higher technology than ICSI. In fact, it's the simplest and the easiest thing for your embryologist to do. So please insist that a conventional IVF should be preferred over ICSI. At least at my clinic, for the last 20 years, I have observed IVF versus ICSI. Invariably, the IVF take-home baby rate is 5% higher than with the ICSI group. So please try to avoid unnecessary ICSIs just because she's a poor responder. What really works well for Poseidon 4 is oocyte activation. You can see what we do is once we inject the oocyte, we then transfer that oocyte for 15 minutes to a calcium ionophore activation medium, which is available with all your media companies. Incubate it for 15 minutes, then transfer it to bicarb buffered media and put it back in the incubator. And there is a 3-fold increase in the possibility of getting more top quality embryos and blastocysts. And finally, of course, PGT, whether it is really indicated in poor responders. And this question is best addressed by this recent paper, Opening the Black Box of PGT. I'm sure all of you have encountered patients where PGT was done, euploid embryo was transferred, and still she did not conceive despite a fantastic endometrium, or despite all your reassurance to the patient that you must do PGT to avoid miscarriages, you transfer a euploid blastocyst, and yet she has an early pregnancy loss. So Laura Renzi, Carlo Alvigi, and Ubaldi in 2023 analyzed 400 papers on PGT, 1,600 items, taking into account embryonic, maternal, paternal, clinical, and lab factors, and clearly showed that just by saying you did a euploid blastocyst transfer, you cannot compensate for advanced maternal age, recurrent implantation failure, and if the morphological grade of the embryo was not good to begin with, just establishing euploidy is not going to ensure a take-home baby for this patient. What about the future for poor responders? Of course, today we have to talk only about ovarian stimulation, but there is so much talk about intra-ovarian PRP. Kind of started off when Kakiroglu's publication came in 2022, showing an improvement in antral follicle counts. Mature oocytes increased from 1.7 to 2.7, number of blastocysts from 0.6 to 2.3. And subsequently, he also showed that it's the young group below 38 which has the best outcomes with intra-ovarian PRP. But more recently, we have a huge review and meta-analysis 2024 of all the available studies, and they clearly conclude that it may benefit some women who are under the age of 40 with an AMH of more than 0.2 and at least one antral follicle seen. You might see some improvement in their response. There is no strong evidence for improved pregnancy or live birth rates in high quality trials, so considered to be investigational at present and not a standard care as the European ASHRAE guidelines conclude. What seems to be a little more exciting is, of course, ovarian fragmentation for follicle activation. And this is very simply put, you just do a laparoscopy. You take a small cortical biopsy from the ovary. Your embryologist can make small fragments of that piece. You then create a small pocket underneath the ovarian capsule and re-implant these pieces back into that pocket. The whole idea is to interrupt the Hippo pathway, which regulates proliferation of any organ in the human body. So the minute you interrupt the Hippo pathway, you expect that there will be regeneration of primordial follicles. Of course, more recently in 2025, we have this large publication here where they showed AFC increased in 71%, AMH levels improved in 57%, significant increase in ovarian volume, follicle development and successful oocyte retrieval in all the patients. Fertilization rates were good. 5 of 14 patients had at least one embryo, and of the 11 patients who underwent FET, 2 clinical pregnancies and a live birth were achieved. Of course, there's nothing dramatic or miraculous, but it's not too small as well, and we need to pay more attention to this kind of ovarian activation procedures. And now we have from Manju Jila from India itself a combination of the two, where she does not only intraovarian PRP by laparoscopy, but at the same time the OFA procedure as well. So since you are anyway doing a laparoscopy for OFA, you also do intraovarian PRP injections, and they showed a promising 24% live birth rate following this procedure. But what I really want, since we have to talk of cutting edge and newer advances, what seems to be exciting right now is a full-term stimulation, which might help to improve egg quality in older patients undergoing ovarian stimulation. It's a very nice concept that just as you have a 9-month full-term pregnancy and anything before that is a preterm pregnancy, so also if you look at a normal menstrual cycle, the normal follicular phase is 16 to 17 days. Yet for almost 4 decades, we have been truncating that follicular phase by triggering on day 9 or day 10 and picking up oocytes on day 12. Now, this works for 50, 60, 70% of our patients. But what about those who fail to give you even one good embryo? So currently, this is restricted for patients who have failed 2 IVF cycles, both of which they have not given even one normal embryo to you. So the way it is to be done is to maintain FSH levels within predefined limits. As I told you earlier, excessive FSH is not very good for oocyte competency. And as I told you earlier, it is currently reserved for patients with at least 2 previous IVF failures which failed due to either very poor morphological quality or gross chromosomal errors on PGT. So how is it done? You can see here baseline FSH is 8.9 on day 2. So you have to use the long agonist protocol because we are going to stimulate for a fixed 17 days. Triggering will be on day 17, no change in the trigger, irrespective of follicular sizes. You can see follicles have gone to 24, 25, 28, and so on. And you begin, say, with 300. You check serum FSH every few days. Here you see it has exceeded. We want to keep it at almost double. Here it has gone beyond double. So they drop the dose from 300 to 225, and then they maintain 225 to keep the FSH at say 17 and 14.75. And you can see here in her first conventional stimulation, which lasted 8 days, one abnormal embryo, second stimulation 10 days, again an abnormal embryo with term stimulation. She finally gave one genetically euploid embryo. Same way, second patient, you can see 2.8. So the target FSH, serum FSH was to maintain it between 5 and 10. They started with 300, immediately dropped down to 150. 9.5, 9.6. There were days when they even omitted FSH totally by coasting so as to make sure that the FSH did not go beyond 10. And again, 17th day trigger, follicle sizes are very large. Again, first cycle conventional, 3-day, 3 poor quality embryos. Second cycle, no development at all. With term stimulation, she had 5 top quality blastocysts. So for some advanced age women where normal IVF just doesn't give you a good result, maybe allowing the follicle to grow like a normal menstrual cycle to the full 16, 17 days might be better to give you a better outcome. What about LH independent follicular luteinization, which all of you might have thought of as the first thing, that if you wait for follicles to become 25 and 28, they will probably luteinize. And that is where diclofenac in the form of a vaginal suppository was used to prevent this particular non-LH, rather LH independent follicular luteinization from happening. So to conclude, the poor responder, of course, 60 days of pre-treatment for Poseidon 3 and 4, whichever adjuvants you believe in. But coenzyme Q, ARG9, resveratrol, folic acid, vitamin D, melatonin now is something all of us use. Testosterone gel for 20 days. First choice protocol, the long luteal agonist with HMG 450. If that fails, the second would be estradiol or antagonist pre-treatment, followed by the short antagonist protocol, again using a combination of FSH 300 and LH 150. Fresh transfers, very successful in poor responders, especially if all the criteria for fresh transfers are met. And if not met, then frozen embryo transfer. So what is the current evidence from Paris ESHRE 2025? You can see here that DHEA significantly increases the number of oocytes. Testosterone improves clinical pregnancy rates and live birth rates. high dose gonadotropin, which means conventional gonadotropin stimulation and not mild stimulation, will give you better outcomes. A delayed start protocol with GnRH antagonist, as I told you, pre-treatment with the antagonist and then beginning to prevent asynchronous follicular growth is recommended. And also they have clearly said doses more than 300 not recommended. Again, for Indian women, I think 450 should be the upper cap. PPOS or antagonists both are equally effective for all freeze-all protocols. Letrozole and clomiphene add-ons are not routinely recommended for high, normal or low responders. And hormonal stimulation, hormonal monitoring, sorry, is something I really felt very happy about. During stimulation is not routinely needed. So we know that just ultrasound and monitoring is enough in the days of the agonist trigger. We are not worried about E2 levels or hyperstimulations or anything else. So please don't waste time on doing E2, LH, progesterone, and so on if you're just doing a freeze-all cycle. Also very important in a poor responder, if you see one follicle, don't cancel the cycle. There is no guarantee she's going to give you 10 in the next cycle. So please retrieve that oocyte, and there is no reason to cancel a cycle just because she has one or two follicles. Before, of course, finally, we have to talk a little bit about high responders as well, since we are on ovarian stimulation for IVF. There is a lot of research now that in PCO, endometriosis, and in advanced maternal age, chronic low-grade inflammation in the ovary is what causes a lot of the problems that we face with stimulation. So elevated serum and follicular fluid levels of C-reactive proteins TNF alpha, we know that with hyperandrogenism and insulin resistance, there is a chronic low-grade inflammation, oxidative stress, ovarian fibrosis, which then results in oocyte dysfunction. So a lot of therapies are now being targeted in PCO patients to counter low-grade inflammation and fibrosis in the ovaries, with, of course, antioxidants, insulin sensitizing drugs, anti-aging, immune checkpoint inhibitors, and anti-fibrosis drugs. These are going to be the future of management in PCOS, or rather pre-treatment in PCOS before moving on to stimulation. Who would have thought that we would be recommending androgen supplementation in PCOS? And very interesting study here, where instead of phenotypes A, B, C, and D, they now propose that we have only two types. One is HPCOS, which will include phenotypes A, B, and C, and HHPCOS, which will include phenotype D. We know that phenotype D is your lean, thin PCOS patient, the lean BMI. And very interestingly, this study has found that till the age of 25, they are hyperandrogenic. They become normal androgenic between 25 and 35, and they become hypoandrogenic after the age of 35. So there is now an area of supplementing with DHEA, especially for your thin lean PCOS who is above the age of 35. And you can see here for that particular category, there is a sharp drop in the androgen levels between the age of 25 to 35, a very sharp decline. So they need some form of DHEA supplementation for better outcomes. So this is something very interesting for PCO patients. And also, we know that all of us probably use myoinositol, melatonin, which are all now a lot of publications showing that they really help. And we know that myoinositol, melatonin, folic acid, and vitamin D should probably be routine for most of your PCO patients as supplements for 2 months before you begin the actual stimulation cycle. Studies also showing that myoinositol helps to reduce the occurrence of neural tube defects in this recent study in 2024 in your PCOS patients. And just as with your poor responders, more attention now being paid to mitochondrial activity. You can see here coenzyme Q10 again being proposed in addition to myoinositol for improving mitochondrial integrity in PCO patients, especially in your obese, insulin resistant, and very severe PCO patients. Definitely coenzyme Q10 will help to reduce your early pregnancy losses. Also interesting research on probiotics, and you can see here significant depletion of parabacteroids MURDA in PCO patients. P-MURDA depletion and BCC elevation may serve as emerging biomarkers for all the reproductive risks in PCOS. And just as we now have targeted probiotics for semen and for the endometrium, probably we will also have a targeted probiotic for improving the ovarian environment in PCO patients. So we had a lot of challenges. All of you were aware of the hyperstimulations and the explosion of the ovaries, whatever dose of FSH you gave. But 1 to 5 is probably conquered now. thanks to the agonist trigger, we no longer have 1 to 5, but we still deal with a lot of early pregnancy losses. So why have 1 to 5 been conquered? Because of the 3 musketeer approach. We know that you have to use the antagonist protocol, you have to give the agonist trigger, and you have to do a freeze all to make sure that you are a zero OHSS clinic with your high responder PCO patients. But again, a practical pointer here, that what about OC pills? And there is common practice to give OC pills to PCO patients to regularize their menses, to so-called induce a bleed so that you can start stimulation. And as I told you earlier, please look at the recent literature that we have. Women with PCO who start stimulation following a spontaneous menses had higher live birth rates compared to those who were on oral contraceptive pills. So many papers over the years clearly showing slower follicular growth, higher consumption of gonadotropins, lower live birth rates, and increase in the miscarriage rates when OC pill pretreatment is done for PCO. But what is more recent, and this paper from 2024, because many a times there is a practice to check LH levels on day 2, and if they are high, then the patient is put on a OC pill pretreatment, thinking that we need to reduce LH and then start stimulation for a PCO patient. So this study compared 2 groups of both having high LH on day 2, one where OC pills were used, a 7-day washout period was given, and then FSH was started, and the other group where the high LH was ignored and stimulation was directly started on day 2. And clearly they showed that high LH levels on day 2 did not have any negative impact on embryo quality. So please do not give her OC pills, because you will then render the agonist trigger ineffective because of oversuppression of endogenous LH. And this slide clearly shows that the lower the LH level at the start of stimulation because of prolonged OC pills, the higher is the proportion of cycles which are going to give you a suboptimal response in terms of number of metaphase 2s and top quality embryos. Also very interesting now that we take the upper cap of FSH for granted in PCOS patients, thinking that, oh, it's better to overdose than underdose. But again, as I told you, overdosing can cause follicular asynchrony. And you can see why we need to use this nomogram and do an individualized dose selection even for PCO patients. For example, a PCOS with a BMI 28, a basal FSH of 6, basal LH 8, AMH of 8, and AFC 24, the nomogram clearly shows that the FSH doses is 125. Now, if we were to give her 200 or 225, as another study shows here from 2025, that you will have a higher percentage of follicular asynchrony. So again, you can see the individualized dosing with the use of the nomogram reduces the percentage of follicular asynchrony from 37.5% to just about 2.3%. So more and more fine-tuning and individualization required for every patient who walks in for an IVF cycle. What about PPOS? Of course, we know that it has a lot of advantages. It reduces the number of injections that are to be used and so on. And Chen, in fact, showed higher clinical pregnancy rates with PPOS generated embryos as compared to the conventional short antagonist protocol. You can see here with PPOS 62% versus 47% with conventional short. So maybe PPOS in fact might be better way to go with a lot of your PCO patients. And you don't have to give 10 milligrams of medroxyprogesterone. You can also use 20 milligrams of dydrogesterone and have the same efficacy. And now recent studies showed that they are all equivalent, whether you give 10 or 2.5 of MPA, you use 20 of dydrogesterone, whether you use 200 or 100 of vaginal, or even one tablet of MVP 200 milligram orally suffices to eliminate the premature LH surge and premature ovulation. So PPOS, of course, is recommended for all your freeze-all cycles. Reducing miscarriage rates, one final important paper before I leave you. We all know that myoinositol, coenzyme Q, probiotics, maybe the Megaset HR trial, which showed that HPHMG helps to reduce early pregnancy losses. But do we have something new for the early miscarriages that we see in PCOS? And all of you who attended the recent IFS and ISAR, you must have heard this presentation live in person. I think Atsuo Itakura himself was here, and he has now proposed a new modified protocol, again on the same concept of delaying the triggering, just as in the term stimulation for poor responders, to help reduce early miscarriages by giving you more competent oocytes. So to leave you with this is what he proposed: FSH 150 from day 2, switch to HMG 150 from day 7, Antagonist is added not at 14 millimeters or a fixed day start, but when the lead-in follicle reaches 18 millimeters. Agonist trigger is given not at 18 mm, but when the largest follicle is more than 24 mm. One tablet of letrozole on the day of trigger if E2 level is 4 to 5,000, and two tablets if the E2 levels are more than 5,000. And he compared all the four groups: agonist, antagonist with HCG trigger, antagonist with agonist trigger, and the new modified stimulation, and clearly showing live birth rates 18, 27, 25 up to 36%. Miscarriage rates reduced from 24, 29, 30 to just 19%. And therefore, the cumulative live birth rate went up from 30, 38, and 37 to 57.4%. So two very interesting new concepts in both poor responders and high responders of trying to mimic the natural menstrual cycle in terms of the length of the follicular phase and the triggering to get better outcomes. So once again, thank you so much, Dr. Jyoti, Dr. Ameet Patki, Asha Baxi, Haryana, ISAR, all the organizers and the sponsors for today's session. And of course, we can have some questions if we want to. Thank you so much.
So that was fantastic, sir. The talk, I think we wanted you to go on and on, but I think it was
I thought I was exceeding the time, so I was increasing the speed a bit.
yeah, no, but it was actually a fantastic talk and so many new concepts and thoughts for thoughtful ideas that we can start in our patients of hyper responders and poor responders.
Yeah.
Dr. Maninder Ahuja ma'am is here. Ma'am, your
Yeah,
comments, please.
yeah, I
Hey, ma'am,
wanted
how
to
are
say
you?
especially for him, Jatin, because he's not only the maestro of the infertility, and the way he speaks is, I was just thinking, it's just like Gita of IVF completely. He's talking about, so we can call him now Krishna also. Krishna giving complete because he has covered so nicely, and he has the power to say, go back to your roots where you are living. Like go not only ICSI for all, but go for IVF for most of the patients where the perhaps we are missing out those congenital defects now when the people have started thinking of. So that is very bold statement to give in the era where everybody is thinking that we should be able. And so many points you have highlighted, but the main I give you three tips for chronic inflammation. That is definitely coming up as a main futuristic problem of our body, uh, which we are not trying to understand. It's not only infertility, it's aging, it's other chronic diseases. Everywhere you are finding this chronic inflammation. And one of the reasons I think is the pollution. Might be the pollution is because I every day say I clean my ceiling fans and everything, and every after 3-4 days they are covered with the black soot. What is happening to our lungs? What is happening to our body? We are breathing daily. So it was a wonderful talk. I mean, going back and discussing all the things won't be possible, but I think you can make some points for the ISAR, at least for people like us to go again and again where we can reach out and learn and just get through these pearls of wisdom again whenever we want to. You can put it on your website or somewhere, different
Sure, ma'am.
protocols and everything.
Yeah,
And
sure.
thank you very much. And really wanted to be here, could not join from the laptop. I think some software problem is there. So anyway, joining from the, and it was nice seeing you. And Jatin,
Same
you are
here, I was
looking
looking for
younger.
you. Thank you, thank you.
You are looking younger. I had actually viral fever for 5-6 days, but I didn't want to miss your talk at least.
Thank you,
Thank
madam.
you very much. And thank you, Jyoti, for inviting me because I'll never miss your invitation anyway.
Thank you so
Thank
much,
you.
ma'am. Thank you.
Yeah.
We invite you when we invite pearls from all over India.
Yeah.
That time I actually don't I make it a point to invite you. So there are one or two questions that somebody is asked in the chat box. One, they want you to elaborate on the use of testosterone gel. 1%, how much needs to be applied?
One
So
actuation twice a day for 20 days. Before you start stimulation, don't give it after you start stimulation. Another very important word of caution is that DHEA also, we just give it to the patients and say you keep taking for 2 months, 3 months, 4 months. Now there are studies that inadvertent DHEA exposure during early pregnancy will cause the female offspring to have a low ovarian reserve. So please be very careful. Instructions have to be given to them. At least they have to stop the DHEA or any kind of androgen 3 weeks before embryo transfer is proposed.
Right.
Sometimes
And
that is forgotten, when we are busy, we just, keep taking. Then suddenly she'll show you, I am taking all these supplements. So resveratrol and DHEA, you have to be very careful that they have to be stopped in time.
right, sir. And the other question is, does OFFA make the procedure of OPU difficult?
No. OFA is done laparoscopically. That is a separate procedure. Laparoscopically, you will do that cortex biopsy, make fragments, reimplant them, do the intraovarian PRP, then wait for 1 menstrual cycle and then do a regular stimulation and pickup. You're not changing the position of the ovary. So pickup is not affected in any way.
Right. Chavi, would you like to comment? You are the chairperson. Any other chairperson that we have? Dr. Maninder, Dr. Meenu and Dr. Anjali, if they're your comments, please. Otherwise, Dr. Chavi, would you like to say something?
Nothing, ma'am. It was just a very elaborate and crisp talk. I would like to thank sir and you.
Yeah, absolutely. Amazing talk. And we will get the recording very soon so we can go through it number of times because he has told us many new things. Which
Yes, ma'am.
we just knew that it was something new which he is talking about. So once we get the recording again, we'll put it on the group so everybody can just go through his talk again. Thank you so much, Jatin sir.
Thank you.
And moving on to our next talk, for that we have our chairpersons, Dr. Manju Dagar, who's the clinical secretary of Haryana ISAR. We have Dr. Niharika Sharma. Dr. Niharika is from Faridabad. Then we have Dr. Kalyani Swami from Hisar, and Dr. Minakshi Mehta from Hisar. And for this, we have another very, very interesting talk. This talk I have heard once, but I wanted to hear it again. And that is why I thought Dr. Surveen would be a person who can do it for us. So can we have Dr. Surveen's CV, please, so that one of our chairpersons can introduce her. Thank you, Dr. Surveen, for accepting the invite and for coming to this platform.
Thank you.
Dr. Manju, can you please do the honor?
Yeah, Dr. Jyoti, thank you so much. Very good evening to all. Good evening, madam. And so it's my pleasure to invite Professor Surveen Goman, and madam need no introduction. And madam has 32 years of clinical experience. Madam wrote many books and is a program director of fellowship program in Max Hospital in reproductive medicine, and executive director of fertility science and research journal, and peer reviewer of the journal System Biology in Reproductive Medicine and Journal of Obs and Gynae of India. Journal of
Everybody can read it. So should we go on to the talk?
Yeah, ma'am. Thank you so much. And yeah, I welcome you to deliver your talk. Please share your screen, ma'am.
So at the outset, I would like to thank Jyoti. I think she does very good webinars. And Team ISAR, Ameet and Asha, and Haryana ISAR, the whole team, Meenu, you, all of you. It's always a pleasure being on board with you. So the previous talk was very good. I think all of us learned a lot, and I also felt that in many ways it has justified some of the things I am going to say. So basically, I am going to be talking to you about follicular size, which is, I think, one of the most important things to base our decision on. Everything is working around the follicular size. So controlled ovarian hyperstimulation is a crucial step, which we all know. Ovarian follicles grow at different rates. Like Jatin said, that there are some which are growing till 17 days. And controlled ovarian hyperstimulation monitoring is usually guided by the follicular size rather than their competence. Now, this treatment is therefore based on the assumption that the follicular size is predicting the developmental competence of the oocyte. Now, we say that the follicle has reached 18 mm, so it is a mature follicle. But that may not be the case. Maybe follicles which are smaller may also be mature. Larger ones may also be equally good. The correlation of oocyte competence with follicular size after controlled ovarian hyperstimulation has not been well characterized. We are still following that old norm of follicles reaching 17, 18, 3 follicles and trigger. Now that actually has changed quite a bit. How do you relate the follicle size at retrieval to the size at trigger time? Now, follicle size on the day of trigger, the follicles are growing by 1 to 2 mm per day. So the follicular sizes would be expected to be 3 to 4 millimeters smaller than the comparable studies assessing the follicular size on the day of the retrieval. That means on the day of the retrieval, when it often happens with us that we trigger, and when we are doing the pickup, we find that, oh, these follicles look really big. I did not trigger at such a size. And that's because the follicle continues to grow. A 12 to 19 mm follicle, you will find it as 16 to 22 mm on the day of retrieval. So don't, it's fine. Your decision was fine. And 12 to 19 mm is the size recommended for trigger. Till when do you stimulate? Now, this is especially very, very important when a patient has very few follicles. They're just 2 follicles. You want to be very accurate in your triggering to make sure that these are 2 competent M2 oocytes inside. What does delaying the trigger do? If you delay the trigger by 48 hours, you find that there are 1.3 fewer follicles of 11 to 14 mm. That means the smaller follicles have reduced and become bigger. And 3.1 more follicles of more than 17 mm. That means they become larger than your mark of 17, 18 mm. Well, they may yield post-mature oocytes, and there may be an untimely rise of progesterone out of making the endometrium out of phase. Associated rise in progesterone is more likely if there were a greater number of larger follicles. That is, your premature progesterone rise is going to be more if you have more than 19 mm follicles on the day of trigger, or the duration for which the larger follicles are present before trigger administration. That means you may have 2 follicles which are big and you're waiting for the smaller ones to grow, and those big ones have been there around for a long time. These are the cases where you will find you have a progesterone rise. Now, what is the impact of follicular size at the time of retrieval? One is that a very small follicle less than 1 ml or a larger follicle more than 7 ml will have statistically lower oocyte yield when compared to those which are of optimum size. They will also have a lower number of mature oocytes. That means that a 13 mm follicle will have a 70% less compared mature oocytes than an 18 mm follicle. What about the fertilization rates? Well, they're not bad. They're not very different. 57% 10 to 14 mm follicles, 69% is the optimum size follicles, and 73% as the follicles become bigger. So what we are finding is that the fertilization rates are becoming better as the follicle becomes bigger. But overall, the follicles 16 to 22 mm on the day of oocyte retrievals are the ones which contain maximum mature oocytes. And how do you correlate these follicles to the, while you're doing the retrieval, how can you correlate a follicle? By looking at the amount of ml which is coming out. So, 2 ml follicle is something between 16 to 18. So, and if your follicle is about 5 ml, the follicular fluid, then that follicle is round about 20, 22 size follicle. Odds of retrieving a mature oocyte as per follicular size decreases as the follicular size decreases. Is there any difference in IVF and ICSI? So odds of fertilization, now the odds of fertilization are going to decrease as the size of the follicle is decreasing. So if the oocyte is mature, it is equally likely to fertilize by conventional insemination or ICSI. So ICSI and IVF are not going to make a difference to the oocyte fertilization rate as long as it is an M2 oocyte. Now, does the original size of the follicle make a difference? Fertilization rate of mature oocytes, that is only M2 oocytes, derived from any size of follicle. less than 18 mm is not statistically significantly different among themselves. That means if you get a M2 from, let's say, a 12 mm follicle and an M2 from an 18 mm follicle, their fertilization rates are going to be absolutely similar. There is no difference in the fertilization rate. What about follicular size on polyspermy? What they have found is that the smaller sized follicles have a higher rate of polyspermy. So that is one thing you have to look out for. If you have a cohort of smaller follicles and larger follicles, always be very careful of polyspermy occurring. So you must do your fertilization check at 19 hours. Oocytes with nuclear maturation, regardless of its follicular size of origin, has equal fertilizing capability. But does it yield equally good embryos? So we are saying that fertilization is the same whether it is a smaller follicle or a larger follicle. But is the cytoplasmic and plasma membrane maturation also equally good? Well, there are no good markers for this. And a variety of morphological oocyte parameters have been used as surrogate markers for quality of the oocyte, but you can really not say. And what is the relationship of the follicle size to fragmentation? It was found that as the follicle size decreases, the average fragmentation score increases. And it was 10% less for embryos derived from the lead follicle compared to the smaller follicle of 10 mm. So that means that there is a quality difference occurring here, despite the fact that they may be fertilizing an equal amount. Does the fertilization method make a difference to the fragmentation? That is, whether it's ICSI or it's a conventional IVF? No, it's all equal. That does not make a difference. What about mature oocytes rate, which was significantly higher in the large and medium compared to the smaller group? So we do know that the M2s were much more in the larger follicles. Although whether the M2 came from the smaller or the larger, it fared the same. There was no in-between group difference observed in fertilization rate, neither in top quality embryo rates among the mature oocytes, regardless of the follicular diameter in which they originate. That means even your 12 mm follicle will yield an equally good embryo if it is an M2 versus an 18 mm. So this is actually questioning the law of 17-18 mm trigger. Now, let's look at this very interesting study in 2020. They categorize small follicles and large follicles. Normal size follicles less than 24 mm, that is 18 to 24 mm, and large size more than 24 mm. What did they find? They found that the large size follicles, the recovery rate of oocytes was slightly less than the normal size, which I think we find in clinical practice, but the fertilization rate and the top quality embryo rate was the same. In fact, maybe a little better with a larger size embryo. While a non-significant decrease in oocyte recovery rate was found in follicles more than 24 mm, the zygote and top quality embryos per follicle were comparable. Let's come on to the smaller follicles. So this was a very interesting study in 2018, which showed that 8 to 12 mm follicle was one category, and you can see the ml written there. That's how they categorized. So they retrieved, and anything less than 1 ml was 12 mm follicle. 1 to 6 ml was a 13 to 23 mm follicle, and more than 6 ml was a 24 mm follicle. It's the same as what I had said, and this was one study I had conducted with a fellow for a thesis. So oocyte recovery, yes, is definitely increasing as the follicular size is increasing. The fertilization rate is absolutely equal amongst all these once the oocyte is recovered. The blastocyst rate is also equal. And the live birth rate is also equal. In fact, here the smaller follicles are showing a higher live birth rate. So the optimum follicle volume for a high yield of good quality blastocysts is about 13 to 23 ml. So when you're retrieving your follicles, if you just look at the test tube and see 1 ml to 6 ml, you know that this follicle is of a good size. Oocytes derive from smaller follicles. Now they still have, if you look at this 8 to 12 mm, it is still giving you great live birth rates. It's giving you great blastocyst rates. So always when you're doing a retrieval, go ahead and pick up that even that 10 mm follicle, retrieve the oocyte. You do get oocytes. This is my personal experience, that you get oocytes from smaller follicles, and they do yield you blastocysts, and they do yield you pregnancy. So don't leave out any follicle. Now, impact of follicle size and homogeneity of follicular development on morphokinetics. So, let's say that there's a discordant growth, like Dr. Jatin had spoken, that large and big small follicles together. So, there could be a large follicle from a heterogeneous cycle, that is a large and small happening. The large follicles from homogeneous cycle, where they're all large. Small follicles from a heterogeneous cycle, that means the smaller follicles, whereas there are some bigger ones. And small follicles from a homogeneous cycle, where they were all small follicles when she was triggered. So this was the study which they conducted, and they compared various things. What they found was that the small follicles where there is a discordant growth, embryos showed significantly higher rates of developmental arrest. Abnormal morphokinetic patterns such as direct cleavages were occurring. And here you can see that the small follicle, this is a cumulative developmental arrest on one side, and the smaller follicles have a much higher developmental arrest. The blue ones are smaller and the red ones are larger follicles. So they are showing a higher developmental arrest. And why is this so? Because a low oxidative phosphorylation rate from the zygote to the morula stage limits the ROS species production, thus maximizing the viability. And a high bioenergetic level of the smaller follicles is leading to a precocious burnout reflected in morphokinetics. So it is because of a higher bioenergetic level, there is a developmental arrest occurring in these follicles. Now, when you look at a homogeneous cycle versus a heterogeneous cycle, does it make a difference to the blastocyst rate? So in a homogeneous cycle, what do you find? You find for follicles derived from a homogeneous cycle, the odds of resulting in a top or good quality embryo was 1.3 times that of a heterogeneous cycle. And this was statistically significant for both good quality blastocysts and top quality embryos. Okay. So that means that a homogeneous cycle is always better. What about large versus small follicles? For large follicles, the odds of developing into top or good quality blastocysts was 1.8 times larger than the odds of a small follicle resulting in a top quality blastocyst. So, when there is a heterogeneous growth, the larger ones will fare better than the smaller ones. So, when there is a homogeneous growth and a heterogeneous growth in another patient, the homogeneous is better. If there is a heterogeneous growth within that patient, your larger follicles are going to be much better. So whenever you are triggering, try and get maximum number of large follicles if you have a discordant growth. You can wait and continue your stimulation. Like Jatin had showed 17 days of stimulation, that is what is happening. You're getting them up to a level where probably you get more large size follicles, and hence the cycle fares better. Impact of follicular size in homogeneous follicular development on early human development. What they found is homogeneous embryos outperform significantly the large ones. They outperform the small group in terms of maturation, fertilization, blastocyst formation, and top quality embryos. So if there are two patients, one with large follicles which are homogeneous and the other with small follicles which are homogeneous, go for the large follicles because they will fare better. So that means you need to increase your stimulation to a time where the follicles are much larger versus follicles are smaller. All embryos reach, but remember that in all this discussion, if your embryo has reached 8 cell stage, it will perform well or similarly irrespective of the size of the follicle, and there is going to be no difference in the developmental progress till blastocyst stage. So follicular size to time to blastocyst. Now embryos from small follicles developed faster. That is what they found because they had more energy than embryos originating from larger follicles. So high bioenergetic levels was the reason for it. Clinical implications. In practice, the selection of embryos based on their rapidity may erroneously deselect embryos developing from large follicles. Whereas the ones from large follicles, although they're developing slowly, may have a higher implantation potential. So Too slow and too fast, both are not good. And it's best to select an embryo which is not growing very fast. Now, one other possible explanation for the different early developmental characteristics of an embryo derived from small and large follicles could be a difference in cytoplasmic competence. Because the mitochondrial pool, RNA and protein of an embryo were derived from oocytes, the quality of follicular growth directly impacts the quality of the embryo and its viability. And this is reflecting the morphokinetic variability. Now, what about the follicular size relating to euploid status? And this was again a very interesting paper in Human Reproduction 2020, where they tested, they had segregated and kept separate the smaller follicles and the larger follicles. And then they went in for a PGT-A, and they found that there was no difference in a blastocyst as far as the euploidy rate is concerned, whether it was derived from a smaller follicle or a larger follicle. So all differences as far as the size is there go once it develops into a blastocyst. Now, coming on to the older age women and poor ovarian reserve women, do we need to change our trigger time for their follicles? So again, a very interesting study where they highly individualized the egg retrieval. There were two sets of women. One was women more than 43 years old, and the second group was 37 women of POA, where there was a decreased premature reserve. They isolated the granulosa cell and they cultured them, and then they studied them for FSH, LH, progesterone receptors. And LH and progesterone receptors were markers of premature luteinization. Then what did they do? They divided the trigger groups into very early retrieval, where the follicles were only 13 to 15 mm, early retrieval where it was 16 to 18 mm, and standard retrieval of 18 to 20 mm. And in the POA group, it was just two groups, the early retrieval and the standard retrieval. What did they find? In the older women, they found that the early retrieval, that is the 16 to 18 mm, was the one which fared best. It had maximum number of oocytes and mature oocytes. It had a percentage of higher quality of embryos, 83 versus 52 and 34. And look at the pregnancy rate, 3 times, 16% versus 5 and 6% in the other groups. But the markers of premature luteinization increased as the follicular size increased. That, of course, will happen. The progesterone will go up. What about premature ovarian aging women? Again, the early retrieval showed percentage of more mature oocytes being much more, 80 versus 55. And clinical pregnancy rate, look at the clinical pregnancy rate, 41% versus 7%. So again, the oocyte, the premature luteinization was much more in the larger follicles. So coming to an end as far as the follicle size is concerned, while tailoring the time of ovulation trigger, an absolute understanding of size is needed to produce the right results. So true for ovarian stimulation, you need to individualize even your trigger time, your follicle, decide which is the best time to trigger, whether if there are smaller follicles, should I wait and let them become bigger and the bigger ones become even more bigger? We can do that. That's a good idea. Or we trigger and we make sure that even the smaller ones are retrieved and we don't leave them out. Yes, size matters. In oocyte retrieval, the fish you catch depends on the size. Thank you.
Thank you, madam. It was a very nice lecture on the follicle, on the volume and the fluid and the size and the individualization of trigger. It's very nice. And anyone has any question? It was eye-opening, like in PCOS, sometime we are afraid of OHSS and we try to trigger at the little early so that to avoid OHSS with the agonist though, but the size is important, so we need to wait more.
Yeah, you shouldn't be scared of waiting now because the agonist trigger is there. I fully stimulate my PCOS. I do not in any manner compromise on the stimulation.
Yes, ma'am.
Yeah, so that was a wonderful, wonderful talk again, Dr. Surveen. And this Dr. Jatin has also commented for you. Lovely talk. So from the, I mean, two very, 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 I think, mind-boggling talks that we could hear today. So I think this is what I can gather is that, okay, we should not be like hooked on to 18, 20 mm. We
Yeah.
can go to 20, 24. And this way you've decided, give us four groups: homogeneous, heterogeneous, small, and homogeneous with the small. And I think there were four things where then you said that if it is homogeneous, heterogeneous, then you should look for the bigger follicles.
Yeah, yeah.
So
That's what I actually do in my clinical practice. I let them go to 24. I make the smaller ones come up. I do not trigger at that typical formula of 3 at 18 mm. No, I don't do that. I individualize every patient.
okay, right. So I mean, if all the follicles are nearly like 16, 17, you still wait for 2, 3, 4
Yes.
days more, so
I'll
that
wait for them to reach 20 if I've got smaller follicles. And otherwise, also, I always trigger at around about 18 to 20. I don't trigger before that.
yeah.
And
So
one follicle, if there's one follicle which is growing large and the others are smaller, I ignore that follicle totally. I totally ignore it and carry on the stimulation.
right. So we should be going by the more, I mean, the dominant cohort, what is growing, rather than one or two odd men out.
Yeah.
We should ignore those. And another thing that you've also suggested is that even smaller, try to aspirate whatever you can, even smaller follicles, 8 mm, 10 mm, 12, 14 mm. I mean, you just try, because those also, at least 50% of them will fertilize and give you many more, add to your number of embryos that you can have. So I think very important and very nice message, Dr. Surveen. Thank you so much for that mind stimulating talk. Dr. Kalyani, your comments, please. आप वो करो, unmute करो.
Thank you so much, ma'am. Thanks a lot to Dr. Sureen and ma'am Jyoti ma'am. It is like very challenging and eye-opening topic, and me to learn a lot. Like you have told, like heterogeneous and homogeneous. Till now, I was using that 16, 18, 20. So now onwards, I will see like more and more size to come out. Thank you so
Much
much, ma'am.
answer.
Very much informative for me. Too. Thanks a
Yeah,
lot, ma'am.
for everybody.
Yes.
There's a question for you, Dr. Surveen. In heterogeneous group, what size of follicle should we trigger?
So in heterogeneous, you have to look at, let's say there are 2, 3 follicles which are big and there are about 6 which are small. I would let the bigger ones go, let them
Correct.
become larger till the smaller ones have reached about 16 mm. And then I would trigger.
Right.
Right.
And that often happens with us, you know. Suddenly there are just 2, 3 follicles which are growing, and the rest, she's had a good antral follicle count, but the follicles haven't come up. Then I think just wait. That's another thing which I use with these
Ma'am,
patients.
with these large follicle, if we aspirate, did we, matlab, we find the mega oocytes sometime, over mature oocytes. So it means we are losing all these 3 eggs, and we are matlab, waiting to coming up for the more 4 to 6 eggs.
That is one thing. Another thing is that more than 24 has been shown to yield pregnancies. It's not that it hasn't been shown to yield. And I did do this thesis with a fellow where we actually categorized each follicle and separated each oocyte of the larger follicles and the medium size and the smaller follicles. And the papers which I presented are actually true. Even the larger ones are giving you the same amount of pregnancy rate. Even the smaller ones are giving you the same amount.
And sometime we wait for for next 2-3 days, and the bigger follicle will grow more bigger, and the smaller follicle will arrest at that stage only and not coming. Do you increase the dose also?
No, I don't increase the dose. I do use a growth hormone, which acts very well.
Okay.
I mean, I've seen that patients respond very well to this discordant growth where there are smaller follicles and the others are growing. I start a growth hormone and I see the smaller ones start growing.
Sir, how much growth hormone you are using?
I give 4 MIU.
And at that stage only, or you in the next cycle you are planning for the growth hormone?
No, that stage for that
That cycle.
salvage that cycle, I give it at that stage.
Yes.
But if I have to stimulate her again, then I know that this has happened, and I probably would give it on day 1.
Okay.
So maybe
Okay.
3 to 4 injections of growth hormone, and we can, I think that cycle we can sort of salvage.
Yeah, they come up very well. I mean, there are studies which say growth hormone doesn't act, but my personal experience has been that these follicles come up very well with it.
Okay.
Okay.
Right. So thank you so much, Dr. Surveen. It was wonderful to
Thanks
have
for
you.
having me on board.
And with the topic which is which can I mean, even small little these sort of inputs in our day-to-day practice do really matter a lot. So thank you so much, and I'm sure all the participants who had joined with us must have got so many take-home messages today from these two talks. And I think the dose of growth hormone that already you've said. And is there any specific reason why follicles more than 24 yield no eggs or less number of eggs?
They
And
become hypermature, na? So they tend to.
right. So the dose is 4 IU per day. From which day she's asking? So that already she is told, Dr. Suveen, that in next cycle she would like to start from the beginning, from day 2 of the stimulation. But in this cycle, whenever she sees that there is a stagnation and the eggs are not growing, from that particular day, along with the gonadotrophins, you add the growth hormone. So thank you, everybody. Thank you, both the speakers, Dr. Surveen, Dr. Jatin. I'm not sure whether sir is here or sir has left. And thank you all the dear chairpersons, Dr. Maninder Ahuja, Dr. Meenu Bhakar, Dr. Anjali, Dr. Chavi, Dr. Niharika, Dr. Kalyani, Dr. Minakshi, and Dr. Manju for being with us today evening. Thank you, Nimisha, and thank you, Jackson Paul. Thank you so much.
Thank you so much.
Over to you, Nimisha. Thank you.
Thank you, ma'am. So thank you for joining in today. The session was brought to you by Jackson Pal Pharma, the makers of Endorex, Divatron, and Maintain Injection. So thank you, and we look forward to your participation in the next webinar.